Hello, it's Jess again. So let's talk about gout. Gout is something that you may have not heard of before, but there's probably a fair amount of things that you haven't heard of before coming into nursing. Um, but this may be one of those things. So I'm going to share my screen. We will take a look at the process of gout. Let me take a look at the slideshow, and we're going to progress from current slide. There we go. So gout is a type of arthritis, inflammation of the joints, arthritis, characterized by hyperuricemia, lots of uric acid, and the deposit of uric acid in more than one or more joints. So those sodium urate crystals can start articular, they can be a kind of around in the joint, just around the joint, or in subcutaneous tissues. You might find these buildups of uric acid crystals. But the painful flares last for days to weeks. Then they go asymptomatic. So this is definitely a waxing and waning sort of situation as well. There is a high, the incidence is greater than 8 million people in the United States. Sorry, I thought I still had my pen turned on. Turn on my pen and pick a pen color. Let's go there. And then it does affect Black people more than it affects white people. Men are 3 times more likely to develop it than women. It develops usually between ages of 30 and 50, and women rarely have gout before menopause. Fun fact. So the etiology is that the uric acid is an end product of protein metabolism, purine specifically, and it generally gets excreted by the kidneys. So if there's being too much purine being metabolized, or that as the purine is metabolized, if there's too much uric acid made from that metabolism, or if the kidneys can't keep up, this is where we have these uric acid crystals building up. There is primary and secondary with this. Primary is determined, it has a genetic etiology. Secondary results from either increased production or decreased excretion, or drugs that inhibit uric acid excretion. Organ transplants, recipients getting immunosuppressants are also at risk. And another cause of secondary hyperuricemia is in our oncology population, because they are having that chemotherapy can be banging on our muscle cells. And we talked a little bit about that in heart failure as well, that chemotherapy affecting those cells. When we have the muscle destruction, that's also causing purine metabolism and high levels of uric acid. So we may also see this in people who are getting chemotherapy. It's caused by interaction of factors. So there's the metabolic part of the purine metabolism. Intake of high purine foods, prolonged fasting. Again, chemotherapy people don't really, they can have some severe anorexia associated with their chemotherapy, excessive alcohol use. And there has to be 2 processes. There has to be both crystallization and inflammation. So just so that you're aware that phagocytosis causes increased inflammation and tissue damage. So that what will happen is the body will be like, hey, uric acid crystals, you don't need to be here. So then they say the phagocytes, and the phagocytes create an inflammation reaction. And then the inflammation reaction is just like so volatile that it actually creates tissue damage while it's happening. Clinical manifestations. So it's usually in 1 or more joints, but less than 4. It's commonly in the great toe, and it's commonly in that toe joint where you, if people have been wearing bad shoes and they get bunions, it's that joint right there at the ball of the foot. You can also have these buildups of uric acid crystals in the wrists, knees, ankles, midfoot, the old cranium bursae. It creates it creates color changes. So it can be dusky, kind of like that dark purple. It can look cyanotic, and it's super tender to the touch. Person who's having a gout flare in their foot will not want to use their foot at all. Triggers can be trauma, surgery, alcohol, or if somebody's got a systemic infection, can all trigger a gouty flare. Symptoms usually onset at night. There'll be sudden swelling, there'll be severe pain, they'll be sensitive to light touch, and they'll develop a low-grade fever. The duration of this, it usually lasts from 2 to 10 days with or without treatment. So if they're having a gout flare, they're going to be doing hopefully they're going to be able to do some significant self-care during this time. Chronic gout has multiple joint involvement. And then there's these things called tophi, and the tophi are visible deposits of crystals in the subcutaneous tissues, or synovial membranes, tendons, soft tissues, and they occur years after onset of gout. Here are tophi. So as you can see, they're bubbles or gatherings of uric acid crystals, and this particular person has them. This is the one normal finger. They're in his fingers, they're in their wrists. You can kind of see them in a variety of different spots. The severity of gout is variable. It can involve infrequent mild attacks. It can be multiple severe episodes, up to like 12 a year, with a slow progressive disability. And the high serum acid increases in episodes in tophi. So the more episodes they have of this high uric acid in the blood, the more episodes they're going to have and the more tophi they're going to be developing. Chronic inflammation can lead to joint deformity, cartilage destruction, and secondary osteoarthritis. Large crystal deposits may pierce the skin, like we will make the skin pop. And then that drains the sinuses of those synovial joints. It can cause infection as well because you've got this large open large opening in the skin that goes all the way down to the joint. Excessive uric acid excretion also leads to kidney or urinary tract stones. Gout is the #2 cause of people who need dialysis. So #1 is the diabetes and #2 is the gout. The kidneys, simply just like with people who have complications from diabetes and they end up with kidney failure, the kidneys just aren't built to handle that much acid, and they fail because of the excessive amounts of acid. So for diagnostics, we're going to be taking a look at serum uric acid, and if it's significant if it's greater than 6. We'll take a look at their 24-hour urine sample. So we'll gather a 2 or 3 liter specific bottles, and we'll do a uric acid test. May do synovial joint or synovial fluid aspiration. They'll be looking at clinical symptoms, and then they may do an X-ray of the affected joint. Goals for these particular people is to, first of all, let's get rid of the attack. And then let's work with these people to control their hyperuricemia and gout between patient education and adherence. The main drug of choice in this particular situation is oral colchicine. Sorry, it's an anti-inflammatory. It's also known as allopurinol. Pain relief usually happens within 12 hours. And if we can administer allopurinol and then we have things happen where the pain is going away in 12 minutes, then we can say, oh, I betcha, I think there's some uric acid problems going on. We can also help them with some NSAIDs. We can help them with some corticosteroids and ACTH. We will be using some different preventative drugs as well. Oh, I misspoke. I'm sorry. So colchicine is an anti-inflammatory drug. It is not the same as allopurinol. Allopurinol is on this next slide. I apologize, my bad. So allopurinol is a very common drug that is taken by people who are gouty or subject to periods of gout. Allopurinol is, I've seen that significantly for or as part of people's medication regimens when they're hospitalized for chemotherapy as well. Some other drugs that you can see on the MAR is the the probenecid, which increases the urinary excretion of uric acid, but no aspirin during that. This Ziramipic is new, and I'm not 100% sure about everything in there, but Lewis probably has some descriptions of that. Sorry about that. And then there's a combination drug that's out there called Zolo, and it's a combination of lesinurad and the allopurinol. Urocosirics can cause renal impairment, so we need to take them with food and water and have at least 2 liters of water a day for intake. There are some alternatives. Cozar, it works really well for older adults with both gout and hypertension, and that losartan does do a nice job protecting the kidneys with that. What we're going to be doing is we're going to be monitoring their serum acid regularly. There'll be dietary restrictions for foods that are high in purine: meat, smoked cheese, and other sorts of foods that are listed in table 45-12, as well as other factors. We need to make sure that they're making enough urine, maybe perhaps taking a look at doing some weight loss, and we're doing supportive care of that inflamed joint. We'll also work with PTOT and bring them in for interdisciplinary assessments of motion limitations and of pain. That is gout in a nutshell. So I'm going to stop sharing here, and I'm going to stop recording, and I will see you for lupus.